you work last night?
24 hours. Yeah.
Thanks for being here.
Yeah.
How many hours a week?
Usually 40, but it's 80 over 2 weeks unless we're covering extra shifts, which we are right now because we have somebody out on having surgery. So, yeah. And we also have another one that's usually we have one on vacation just about every week it seems like. So,
Lisa is an NRP teacher.
yeah. So, I'll just give you a little quick intro. My name is Lisa Pontius. I am a midwife that I started out as a labor and delivery nurse in a community hospital. I did that when I actually had already had 2 children. And it was because I was inspired by the birth of my sister's first child. She was a teenager, and my mother was terrified of being with her. I'll get to that in a minute. This is a lot of my why. Why do I do what I do? We all have it. And my little sister, I was working in a hospital, but not in labor and delivery. And that my mother called me and she said, I need you to come up here and hold her hand. Right now we're trying to look for her husband. I need you. And I'm sitting here and I'm, 20 years old. I don't know anything about birth. I have no clue. But I'm a can-do kind of girl, right? So I'm like, all right, I'll go hold her hand. And I'm like, well, Mom, why can't you stay there? And Mom said, I just can't. So y'all know there's some trauma there, right? And so I went upstairs and watched my little sister turn from my little sister into a mother. And watched her beautifully birth her child, powerfully birth her child. And it blew my socks off. I didn't know what a beautiful birth was. I'd never been at a birth. I'd never watched a birth. And the first birth I saw was powerful. And I thought, whew, what is that in my heart, in my soul? What's blowing the heart up, right? When you go back to explore a little bit about your why, that's one of the things that I always think about. So I thought, oh, I want to be a labor and delivery nurse, right? The woman, though, that was there, that was with my sister that day, was a midwife from another country. And she had a beautiful voice. She was from Haiti. And she had this lovely lilt to her voice, and her just encouraging my sister, and her sitting there with her, she says, oh, just give a little push. And when she did, my sister's baby started crowning with her first push with her first baby. Yeah. And I was dumb enough to think it was always that way, right?
I was just saying, not normal.
The things that humble us, right? And so anyway, she said, oh, okay, let me get the doctor. And he barely got a glove on and the baby just slid out onto his arm, and it was beautiful. So after that, though, my dad came in afterwards, and he sees his grandson and he burst into tears. My daddy's not a crier. And I said, Dad, let's go get some breakfast. And we walked out and I said, what's going on? And he said, well, I didn't know that your mother whether she was going to live or not after you were born. Aww. So when I started talking to my mom about my own birth, I did ask her, what happened? And she said, well, it was back in the day where they didn't tell you anything. And she had gone in and she wanted not to be awake. And so twilight sleep and, multiple episiotomies. They cut her multiple ways, we'll be out with forceps, drugged, and then my mother almost bled to death. And so then she didn't wake up from the anesthesia for over 24 hours. And my dad, when she woke up, he was sitting by the bed crying because he thought she was not going to live. And Mom thought, because he was crying, that I was dead. And so I entered the world with the appropriate drama right there. And I was at a conference years later, and any of you guys know Suzanne Arms? I know Suzanne, you know her, right?
She started a conference for us. Yeah.
Oh, really? Yeah. And she's battling, I think, cancer right now. Yeah. But I was sitting and talking to her, and she said, so tell me about your birth. And I said, oh, well, I have 3 children. And she goes, no, your birth. And I said, well, my mother told me, and I just shared those things. She says, that's why you're a birth guardian. You're working out your own birth. And that just kind of hit me in the gut because I'm like, oh wow, okay. And made me feel like there was a purpose to this longing I had in my heart that I didn't know why I had, you know? Except for that, I loved being pregnant. I loved birthing my babies. I loved nursing my babies. And it was just a seamless journey for me. It was easy for me. I didn't know how hard it was for other people. And so anyway, after all that, the other thing I have to give honor to is the fact that my mother's own birth, her mother birthed in the hospital, and that wasn't common when my mother was born. And they accidentally switched my mother with another baby and sent her home with a different family. They never would have known had she not been a girl and the other baby was a boy. So they got her home, and my grandmother was changing her diaper because she kept telling them, "This is not my baby," and they didn't believe her.
Oh, come on.
So after that, my grandfather said no more hospitals. And my grandmother birthed a lot of babies at home, and then she had to start going back to the hospital because she had problems with her heart. But all of that being said, my grandmother was alive because back in the day, in a log cabin in rural Arkansas, she was a preterm baby. She was tiny. And she was born in December, and it was cold. And a black brand midwife came over and said, if you want your baby to live, this is what you're going to have to do. And she taught my great-grandmother how to feed a premature baby. My grandmother was so small they dressed her in doll clothes. And I don't know if there was some growth restriction too, or who knows, right? But basically they made an incubator for her out of a fruit crate with wool. And then they heated up irons on the wood stove and put them around her. And she said she either needs to be in your shirt or covered up or in something warm. And they fed her with an eyedropper, and she went on to birth 9 children, one of which was my mom.
How many weeks was she?
They said 2 to 3 months early.
Wow.
So there's a lot of scrappy women in my family. So here we are. And I have had a passion for this work for a long time. I started out actually being a co-owner of a birth center in St. Louis area. And we attended home births, birth center, and hospital births. So we did all of that. And that's a quick path to burnout, I'll tell you that. Because once people found out that they could birth with you, and that if you risked out of their care, you could take care of them at the hospital, we were overwhelmed with people. So anyway, all of that being said, I have a great love for community birth. It matters to me. I care about it deeply. I'm so grateful that you guys were allowing me to come and talk with you and get to know you a little bit. I'm going to open confession. I just moved back to Arkansas after 40 years of being away. I just moved back from Asheville, North Carolina in January. And I've been the director of 3 different birth centers, and I said, I will no longer be an administrator. I'm going to be a good doobie and clock in and clock out and be present for women who need me in a different setting. I have worked at UAMS before when my parents were having some health struggles, and that's what's going on now. My parents are both between 85 and 90 and starting to have some health issues. So I came back to be more present with them and be around them as they need me or don't need me. Right now, every day's a new journey, so we don't know. I certified as a NRP instructor with Julie Moon. I don't know if any of you guys know her with Midwives Untethered. So my 2 disclosures is that I do teach community birth NRP with Julie Moon. I do it on the side a little here and there before I took a full-time job again, which is a crazy life for me at this point. And then I also am a staff nurse midwife at UAMS. However, today I'm not here to represent either one. I'm just here as a midwife, right? A fellow birth worker who's tired, as all of you are, and just understand a little bit of the struggles that that journey brings. So I'm grateful to be here. And also for those of you who don't know, the ones that are in the Little Rock area, if your clients do risk out of home birth for some reason, we can accept them into UAMS and usually under the midwifery service, unless it's just obvious that they need to go to surgery or something like that. So I've had quite a bit of conversations with Shay and with Kim on the phone. And so we have a lot of conversations about people that might be coming in or out. We also do risk assessments at our midwifery clinic. And we see patients on Thursdays and Fridays at the Women's Health Building that's over on University, kind of back behind the Cane's Chicken, back behind what used to be Doctor's Hospital.
And it is so nice, and all of our clients are having a great experience.
I'm so glad to hear that.
It's really such a.
And I'd like to
wonderful
say,
thing.
I live in DeQueen, and I had a lady in Nina, and the baby was breached. And I sent, but this was back in December. I think.
Right before I came, yeah.
It was a wonderful experience.
I'm so glad to hear that.
Yeah, because it would have been an automatic section. What was the one she got back over there, the baby had turned. But they induced, and she did have a vaginal, and everything was good.
One of the things that, we're the local freak show at the hospital. So, a lot of the times, they're like, oh, what are they doing in there? Because we're doing whatever we need to get babies born for people that a lot of the times there are reasons why, obviously there's a reason why they're there. And for those that do need a surgical birth, just be known that very recently there was a maternal assisted C-section at UAMS. Like this week.
Who is the physician?
Dr. Rager.
Okay.
Yeah. So it's really, we're trying to make inroads to make things a little kinder for people and a soft place to land. Because it's a hard transition for people. They're mourning the loss of their home birth, and we know that.
I will say I sent in first time mom with SROM at 21 weeks.
Wow.
And I told her in Texarkana, you have two options. You can go to our local hospital. They'll induce you in the next 48 hours and you can hold your baby. But my strong advice is to go to UAMS. They'll do everything possible if you want to sustain this pregnancy. Kept her pregnant till 32 and 6.
Wow.
Yep.
Wow.
It was amazing.
Well, it's a pretty high-tech place, and most things that come through the door are not normal. I'll be honest.
Best NICU ever. My microsurgery was at their NICU. I love those nurses.
They really do work so hard, and they really care about their clients. I'm going to pass around, and I know you guys, many of them, how many students do we have here, or apprentices? Oh, awesome. Okay, that's beautiful. So NRP, is Neonatal Resuscitation Program, and that's something that is by the American Academy of Pediatrics. Now, it is written primarily for hospital birth. A lot of the jargon, when you read the books and stuff, it looks it's very hospital oriented. However, the 9th edition just came out in the last couple of weeks, so it's 3 weeks, I think. What we just found out is there's a whole chapter in the new book that says, for babies born outside of the delivery room, which cracks me up. And basically it's talking about EMS, first responders, and then it has a couple of paragraphs about home births. Of course they say, we don't recommend home births. The American Academy of Pediatrics does not agree with home births. However, we recognize the autonomy of women to birth their babies in the setting where they feel most comfortable.
That's kind of what they thought it is.
And that's something, though, they're finally getting on board. And they also said in there, and we understand that NRP has to be modified for the setting in which people, are birthing. So there are some inroads, and there's some pretty midwifey things, kind of, but anyway, midwifey things that they've incorporated into the new guidelines. So I wanted to pass these out to everybody. And I think I have 30 copies. Would you mind passing those around? And basically what's in this stack, Deb, keep my time for me. There is the new algorithm on the front, which is the steps to take to resuscitate a baby, or evaluate and then resuscitate. And then there's also, on the back of it, there is a thing that talks about the changes between the old edition and the new edition. Some of it's just verbiage, some of it's a little tweak, but there's a couple of pretty significant things that I'm pretty excited about. Now, you wouldn't think I'd get so excited about something like 15 seconds, but let me tell you why. When you flip over, they're now saying deferred cord clamping at least 60 seconds. At least.
Yeah.
Okay, y'all, I have somebody standing by the warmer when a baby is born going 15 seconds, 45 seconds, you know, like something magical is going to happen in that time. And I'm like, baby's still attached, you know. And so anyway, this is a huge, huge deal. They're really going to have a fit when we start having water births. So, and that's the other thing to be aware of. Now, you know, you don't ever hold your breath when you're part of a university system because you never know what your budget's going to be, but they're talking about us having a low intervention center within 2 years. They said the money's earmarked for it, and it will not be in labor and delivery. It'll be down by the ER, and we will have tubs for people to labor in.
Nice.
Yeah, that's a huge, big deal for the university. So now we're in the process of doing a whole bunch of showing them that we're not crazy and showing them the evidence. And it's the main fight, of course, is always with the pediatricians because they think that, you know, we have 3 heads sometimes when we talk about water birth.
Even if they could just labor in water, it would help with.
I know, that's right. And that's what we're like, we would be that part
That would be.
alone. And I think we're going to get that without any trouble.
Yeah, I think that would be.
I think birthing in the water is going to be more of a deal, but also by the same token, you know, we're going to have to take baby steps there. That is one thing I've learned is a little bit of patience. A little bit of patience. All right, so when you look up there, that was a huge, big deal. So deferred cord clamping for at least 60 seconds. And they went on to say within there is that we see that the evidence is showing that it's beneficial for all babies basically to get their own blood. Well, there's a good idea, right?
Imagine that.
I know, it's a big deal. Then the next thing they said is if a baby can't stay attached to the cord because it's severely compromised, that cord milking, umbilical cord milking where you push the blood up to the baby from the placenta 3 or 4 times, is acceptable for babies that are 35 weeks and above. Now, we know that preterm babies don't tolerate sometimes that blood volume that can cause them to have a brain bleed. But 35 weeks and above, they're saying it's an option. I'm just grateful they're considering these things. That was a big deal. The next thing is, and we'll kind of talk through just like our normal algorithm, but another thing is they're actually upping the pressure that you're supposed to use for your initial breaths. Instead of it being 20 to 25 for a term baby, they're now saying 25 to 30. And I think they're just recognizing that term babies vary in size, right? Bigger babies have bigger lung volume. Sometimes you need more to get the lungs inflated on a larger volume, right? Totally makes sense. Yeah, everybody at the hospital has just a freaking, you know, they get very, very upset or worried every time there's a baby that's going to be big, you know. It is hilarious. Coming from community birth back to the hospital is very interesting. I will try to say it in that way.
To be polite.
It's not, yeah. And I'm not generally very polite. I'm generally pretty straightforward, but it's a very interesting thing to see the fear. I've not been around that, you know what I mean? Because I've been doing what we do. And it's a really weird thing to do, to walk back into that everything is an emergency waiting to happen. Well, at UAMS, that's pretty true, okay? Because it is a high-risk referral center. But for normal, healthy women, you know, the being able to see that women can birth big babies, and they do well, it's an interesting thing. So when we have little victories, we get pretty excited, and we go, here we are. So that peak inflation pressure when you first give those breaths, they're talking about now, like I said, they have upped it where for, you can start at 20 to 25, but you also can go up to 30, and then it's okay to do that for that first inflation breath. The other thing that they're talking about is that they're trying to give a little more time. You know how it's like, if in 15 seconds this doesn't happen, you know, you're like, in 15 seconds I can't even get across the room, right? They also have said now that the time period extended from 15 to 30 seconds before you start using Mr. SOPA, you know, when you move your baby and you reposition, you know, change your mask, that kind of stuff. They're saying that instead, if it's not increasing within 15 to 30 seconds. So basically, you have a little bit more time to figure out, is this baby responding? Am I seeing chest rise? All that kind of stuff. The other thing that I'm pretty excited, some of the other stuff is not applicable because a lot of it's about preterm babies, okay? But the other things that are really interesting is that we are also seeing that they are now, how many of you guys in your home birth kits do you carry a laryngeal mask airway? Okay, so the LMAs, they're now saying, you know how sometimes when a baby comes out and it's real, you know, it's waving to Jesus, that's what I call it, when they're just like this, you know, fish-eyed, and you're trying to stimulate them and you're like, we're way past that. You know you're gonna have to give that baby some breaths. That particular guideline now is saying that it's acceptable to drop an LMA and start with an LMA, because you know, yes, I know, right? Because it's hard to get a good seal sometimes.
Yeah.
So they're basically saying that if you think it's warranted, do it. It's okay.
Yeah.
So it's part of their actual guidelines now. So anybody who's NRP certified, or you know has done the NRP work, should be able to do that, and it should not be a big deal. It's not like intubating a baby. None of us that aren't doing it regularly should ever intubate a baby, the way I look at it, right? I mean, and that's one of the things about community birth that's very different than working in a NICU where every day they're in there intubating 25-weekers, right? That's not what we do. But the LMA is foolproof, y'all. You know, it just does a beautiful job. I have some in here, none of you, some of you, especially if you're students and you're just starting out, so you can see what they look like. And just kind of play with them a little bit, and we'll talk about how they go in. They can't go too far. They stop. You just insert until it actually can't go anymore. And then you hook up your bag to it and you ventilate. It's really easy. And it's not as dependent on what position the baby's head's in or getting a good seal. It really is foolproof. And so that to me is just another piece of gold that happened with this. Okay? So this is just something to read through. And does everybody have access to NRP, or is it hard still for people to access it? Does anybody struggle to get access?
Well, hopefully, will you teach our next one?
Well, I have to work that out, because I have been a contractor with Julie for Midwives Untethered, which is an 8-hour NRP class that is geared towards, you know, community birth.
Like Karen's classes.
Yes. And Karen, ours is a little bit of a different philosophy, but it's still very much geared towards when you're not in a situation where you have a red button on the wall, call all the people. Yeah. Julie Moon, that founded Midwives Untethered, she is a former EMT. And so there's a significant amount in there about interfacing with first responders too. And how do we reach out into the community so that they know who we are, and so that we're better received, and so that they also will come in and actually be helpful, as opposed to not, you know.
You know, I have a midwife that lives down in the Calico Rock area, and she contacted her emergency people that would come and taught them NRP.
Yes, and that's another thing too, is they don't have NRP.
Yeah.
That's not even required. They know PALS, and PALS is different, isn't it?
PALS is right.
Right, and it's not, and we all know that, right? It's a whole different thing. And it's a whole level of, they're also taught to come in and take control of the room. That's a
Right.
fireman thing,
Right.
right? They're taught to what they call power up,
Right.
meaning that I'm gonna be the biggest person in the room and I'm gonna take care of this situation. So it is a very hard culture to break into if it, it's different. And the way that they are conditioned and taught. So another one of the instructors with our group is actually a fire commissioner in New York. And so she's a midwife and a fire commissioner. And she is teaching about birth trauma, and she works with the EMTs about trauma responses and healing their trauma. And she also works with teaching them about midwifery and about birth emergencies. What do you do when you arrive at a birth emergency? So it's a pretty cool
Responses from
thing.
EMTs
Mhm.
is powering up and, oh my God, there's a tiny human in there. I don't want to touch that woman. Will you please ride with us? I'm terrified that baby's going to fall out of her body.
Yeah.
And there's nothing in between.
Yeah, it's like one extreme or the other.
Well, and most of them are about 18 years old, they're young, and they've never had any life experiences, a lot of them. And then the other thing is, most of the time when they show up at anything, somebody's dying
Yes.
or there is a dangerous situation. So they're already terrified before they walk in the room.
It makes sense
Not
that they're trained to power up. That
Yeah.
that clears up a lot of
Doesn't it though?
yeah.
I was like, wow, I didn't realize. I
Don't you
didn't
just
ever
like
think
that
that
part?
through, Yeah.
Just a little tidbit for all of us to remember, we stand in a state which is unique in that it is perfectly legal to be unlicensed. And our emergency people and our hospital people really don't understand that. And that is a barrier that I am dealing with right now in Northwest Arkansas that we all have to remember. If you don't have the bridge already, the bridge being the bridge between you as a provider and those emergency people, if you're trying to build it, it is a very large mountain to climb because there are people on that side who are used to that attitude, this is what I'm taught to do, who think, I don't know if you're licensed or not. I don't know if you're trained or not, because we aren't all licensed.
Right.
There is that in their brain.
Yeah. That's true.
We just had a pretty severe shoulder discussion, and we started CPR on the baby and got the baby up and running.
Mm-hmm.
Yeah, and they showed up and took the baby,
Mhm.
out across a cold winter morning without being wrapped up, without doing resuscitation. And once they got it into the van, they're doing this. And I said to the supervisor, do they not know in our opinion?
No, they do not.
No. He said,
Because they're not
let them
trained.
do what they're trained to do. And I wanted to back
Yeah.
away. Yeah.
Well, and I was fortunate enough in Asheville, North Carolina, which was where I was before I came back here, that the culture of trusting midwifery, mountain midwives, all that, and you have a rather significant, what I would call the hippie contingent there, because I actually identify with that. There are a whole lot of people that really are more interested in they're very, very much empowered about their own health. Women who know who they are, they know what they want to do, they know, there are a lot of herbalists, there's lots of acupuncturists. I mean, you can't throw a rock without hitting a massage therapist, right? And so it is so different there. But what's really interesting is that the EMS people are pretty familiar. They're like, oh, okay, it's a birth, okay. They're just not as shocked by anything. Something else I read recently, and then we'll get back to this, was that some of the EMS buses in the U.S. and some of the bigger cities are carrying whole blood now on the rig. Have you heard about that?
Yeah, Austin
Yeah.
was doing
It was Austin.
I
Yeah.
don't think they do that around here.
Yeah.
They want to give O positive.
There was an interest. Yeah. So here's I was shocked by that.
Yes. I
So
was
did you see that? Was it in Midwives Anonymous on Facebook that you saw it?
was,
Or- yeah.
you know,
and then
they-
you knew.
like a year ago, they had a similar story
Uh-huh.
on 60 Minutes, and they were saying, hey, all these doctors are coming back from working, battles.
Yeah.
And
Yes.
they're coming back, and they want to run an ER like that and start doing all this stuff where
Right.
they pick up people and put them in the truck. And so I kind of like the idea of the O positive. I'm not super stoked about that because I'm all
Yeah.
negative.
Well, what they were saying is they they use low titer O positive
Yes.
blood and because O negative blood is hard to come by and O positive is the most common blood type.
Yes.
And so they're like, we'll deal with the consequences of antibodies later, but if this person's dying,